Hi, I'm Dr. Henry Black from the New York University School of Medicine, reporting to you from the American College of Cardiology meeting at the end of March 2008 in Chicago. I'm here with my colleague, Dr. Michael Weber, to talk about the ONTARGET study. Mike, what is the ONTARGET study and what did it show?
Well, ONTARGET's a very simple idea. It's to reproduce the HOPE study. And remember, the HOPE study was a look at ramipril compared with placebo in high-risk people who've had heart attacks, people who've had strokes, people with complex diabetes. And if you recall, Henry, 6 or 7 years ago, ramipril was about 20-25% better than placebo in preventing death, in preventing new strokes, heart attacks, and so forth.
So it wasn't really a blood pressure trial then?
Well, there was a bit of a blood pressure issue because ramipril did reduce blood pressure inevitably to some extent. How much of that benefit of ramipril was due to the reduction in blood pressure? That said, we've now redone the study in ONTARGET. And what ONTARGET has done is compare ramipril, the same sorts of patients, same high-risk people, compare ramipril with telmisartan, angiotensin receptor blocker, and the combination of the two. So 3 arms, ramipril, telmisartan, and ramipril plus telmisartan.
Why did they pick the combination to study?
You know, it's been a very frequently asked question, Henry. Would you want to use more effective blockade of the renin-angiotensin system, combine an ACE inhibitor, which works one way, combine an angiotensin receptor blocker, which works in a different fashion? Could this combined therapy be better than either one alone?
Do we have any instances where we do that?
Yes. We do know in heart failure, certainly fairly advanced left ventricular systolic dysfunction, that there seems to be some benefit. The CHARM study, VALHEFT, some evidence even in the kidney, particularly people with nephropathy and major proteinuria. Perhaps, again, the 2 ways of blockade might be beneficial. So it was a legitimate question, and we had the opportunity of addressing it in ONTARGET.
Now, my own experience is a blood pressure combination that's not terribly effective.
No, you're absolutely right. And if you think about it, Henry, we didn't want a very effective blood pressure combination because we're trying to eliminate blood pressure as a factor in all of this.
We always have the issue of adjusting for the blood pressure differences, and
that's exactly right. Well, ONTARGET answered our 2 questions wonderfully well, because we were asking, first of all, is telmisartan, the ARB, the same as ramipril in terms of benefits? And secondly, would the combination of the 2 be better than ramipril alone?
Right.
And the answers unequivocally were yes, telmisartan every bit as good as ramipril and perhaps better tolerated. Combination, no. Forget about it. In these sorts of high-risk people, identical outcomes to ramipril or telmisartan alone.
Now, this was a so-called non-inferiority study. What does that mean to the practitioner?
It's a statistical term, non-inferiority, and in essence, when we were saying that telmisartan would be non-inferior to ramipril, that's the statistically, politically correct way of saying it's going to be the same, and you couldn't have a more similar outcome.
So if it were non-inferior, as you say, it turned out to be, that means whatever benefit you thought you got from ramipril, you could anticipate the same level of benefit from the ARB.
And the way it turned out, Henry, you could anticipate that with a great deal of confidence. So I'm very happy about that. And if you think about it from telmisartan's point of view, it's just as powerful in preventing events. It's better tolerated, no angioedema concerns, no cough concerns. And if you think about it, so many of our high-risk people are also hypertensive, and telmisartan is a very effective blood pressure medication, so it would be a very logical drug for a lot of those types of people.
Now, you could say we could do this with confidence. I guess that's because this is a gigantic study. How many people were in it?
Altogether, well over 25,000. More than 8,000 each of the 3 groups, telmisartan, ramipril, and the combination. So we had terrific statistical power, narrow confidence intervals, as the statisticians like to say, and as we pointed out, a lot of confidence, therefore, that when we say these drugs are not different or one is non-inferior to the other, we really mean it.
Was there much of a blood pressure difference?
Interestingly, not. Now, we told investigators in the study, please treat blood pressure effectively with whatever you need to do. There was, in fact, less than a 1 millimeter of mercury difference between the 2 treatments. The combination was about 2.5 millimeters of mercury difference. But apparently that didn't mean much because the results were exactly the same.
On outcomes, yes.
Yes.
So you didn't have to worry about adjusting out and explaining or finding an excuse for the difference that you could blame on blood pressure.
No, exactly. Of course, Henry, we are left now with one compelling question, and that is, are we absolutely certain that these two drugs are, in fact, working by something independent of a blood pressure action? And we'll know that answer in just a few months when Transcend, which is a similar study comparing telmisartan with placebo, is going to be announced.
I want to talk a little bit about that and about the tolerability. As I understand it, there was more cough and more angioedema, not only in the Ramipril group, but also in the combination.
Correct.
Is that what was found?
Yes, indeed there was. And it's interesting, Henry, because for a start, we tried to keep people who'd known to have cough previously with ACE inhibitors out of the study. We did a run-in where everybody got an ACE inhibitor for a period of time just to find those people who'd cough or have angioedema, get rid of them, put them into the Transcend trial. So we thought we had basically a cough-free cohort. Not so. Even under those circumstances, a big difference between the drugs.
So if I understand this, if we're trying to look at a number of people who are going to get a cough, or where that's a problem, we can't tell it from ONTARGET because they were enrolled. We may be able to tell it, I think, by adding the people from Transcend who were excluded because of a cough to the people who were in ONTARGET and got it, to see whether or not the tolerability benefit that ARBs have is substantial enough to overcome other issues about them.
Well, exactly so. And I think we're going to have a lot of activity once Transcend is over, comparing and contrasting it to ONTARGET. And in fact, you're right, pooling certain patients to see what we can learn that way.
Because I've seen some interpretations of ONTARGET, which I don't agree with, that, well, ACE inhibitors can't be beat. You know, they're less expensive, and the outcomes are the same. Well, I don't agree with that, and maybe I wonder your opinion. When you have to stop a substantial number of people because of a side effect, and when you're facing a potentially fatal side effect like angioedema, I'm not so sure that the benefit of ACE inhibitors with respect to cost, say, is worth it.
Well, I agree with you completely, and I'd make one further comment even about the ACE inhibitors. We're not talking about ACE inhibitors, we're talking about Ramipril.
Right.
And as was pointed out today at the big sessions where this was discussed, only 3 ACE inhibitors in history have ever saved lives: captopril, enalapril, and Ramipril. So let's be very specific about that. And when it comes to high-risk cardiovascular, only Ramipril. Now, I think Ramipril may be a very special ACE inhibitor.
Well, that could get us into a question that I'm sure could take a little time, and I wonder your opinion about class effect. Do you think there is a class effect for ACE inhibitors? Maybe not.
No.
What about for ARBs?
I don't think there's a class effect for ACE inhibitors. There have been now 2 or 3 publications, admittedly observational, where you can see that when you compare lisinopril, enalapril, captopril, Ramipril, there are differences in important outcomes. ARBs, not so sure as yet, because we don't have comparative studies. We're going to need a lot of meta-analysis, I suspect, before we can answer that question. But telmisartan got very different pharmacokinetics, very different receptor properties, very different metabolism. You just can't make assumptions. For goodness sake, Henry, if you think about it, just look at our treatment of diabetes. You're going to say that the thiazolidine diones are the same. On the one hand, you have rosiglitazone. On the other hand, you have pioglitazone. One increases events, one decreases events. This class effect business is foolish. You have to be very careful before you make those assumptions.
I suppose what we can be confident about is what happens in this patient population with this agent at that dose.
Exactly. We've learned a lot about telmisartan. We know a lot about Ramipril. Let's work with that.
When can we expect Transcend?
Transcend is going to be announced in September 2008 at the European Society of Cardiology meeting. So we're talking 3 or 4 months after ACC. We should know the full story.
Good. Thank you very much, Dr. Weber, and thank you all for your attention.